so we can go ahead.
We'll start with Dr. Vunda, 576 to 585. Hello, Dr. Vunda, are you here, please?
Yeah, I'm here. I'm here. Thank you.
All right.
Very much.
All right. All right.
All right. So I am taking questions 576 to 585, which are a chain of questions. So 576 to 580 have the same stem, and it starts by match each description with the associated condition. Hemochromatosis, A, B, amyloidosis, C, both, D, neither. Now, what are the equations? 576 may result in restrictive cardiomyopathy. 577, early disease is reversible with chelating agent. D, ventricular tachyarrhythmia is the most common initial presentation. 579, autosomal recessive inheritance may be responsible. 580, low voltage PROS on ECG is typical. Just to note that as regards infiltrative diseases, hemochromatosis and amyloidosis are potential causes of infiltrative disease. And we know that hemochromatosis can come about as a result of deposition of excess iron that can be as a result of multiple blood transfusions or an autosomal recessive transmission of a mutation in the HFE gene. Also from other causes of increased iron absorption, such as states of ineffective erythropoiesis. On the other hand, cardiac amyloidosis comes about due to deposition of misfolded products of various protein precursors in the heart. Could be as a result of the AL amyloidosis, which is as a result of light chain, usually from the production of proteins derived from the immunoglobulin light chain by plasma cells. This setting is usually seen in multiple myeloma. There's also a familiar pattern of inheritance for amyloidosis, usually autosomal dominant, and of course via mutation in the hepatically expressed protein transthyretin, that is the TTR. Also to note that there was also a previously termed senile form, which is the wild type TTR, seen in older individuals. Also, we find out that secondary amyloidosis can also come out from systemic inflammatory conditions, especially with serum amyloid A. So one of the things that happens is that, like we said initially, these two, both amyloidosis and hemochromatosis, are examples or part of formation of restrictive cardiomyopathy. As we know, for ECGs in hemochromatosis, they're usually diffuse ST segment and T wave abnormalities, and they can be supraventricular arrhythmias. Also, just to note that abnormal readings like AF can be common in amyloidosis. And one of the things also, because it's an infiltrative heart disease, we can have low voltages and pseudo-infarct patterns. Just to note that if diagnosed early, the cardiomyopathy of hemochromatosis can be reversed with phlebotomy and chelating agents. Just to note about this. So basically, that is a summary of the two conditions being discussed. So going back to our question, may result in restrictive cardiomyopathy, of course, from what I've earlier described. Hemochromatosis and the amyloidosis definitely can result in restrictive cardiomyopathy. So the answer for that would be C, because C is for both. Also, 577 says early disease is reversible with chelating agents. The best option would be hemochromatosis, which is A. So 577 is A. Ventricular tachyarrhythmia is the most common initial presentation. It's false. It's not the most common initial presentation. So it's neither. So it becomes D. Autosomal recessive inheritance may be responsible, as we state, a form of due to mutations of the HFE that can present as a result of autosomal recessive. So that's one of the things we can see in hemochromatosis. So the option is A. Low voltages QRS on ECG is typical. That's what we should expect in we look at that. We'll find out that the options are clear. So that's B. So that's CADAB. So that's what we have for question 56 to 58, which are all joint questions. So thank you very much.
Thank you. Please, what's 580, please?
5. Sorry, I didn't hear you, please.
580.
Okay, low voltage.
I said, what's the answer?
Okay, it's for amyloidosis, so it's B.
Okay, thank you.
All right, please can I go ahead?
Please go ahead.
All right, thank you very much. So the next question is also a joint question with terms, and the question is match each description with the associated condition. Started with A as tricuspid stenosis, B as pulmonic stenosis, C both, D neither. So the first question, 581, is usually rheumatic in origin. 582, typical of carcinoid heart disease. 583, most adults are asymptomatic. 584, ascites is common on physical examination. 585, balloon valvuloplasty is the treatment of choice. So to talk a little about the same condition, So presented to us is tricuspid stenosis and pulmonic stenosis. Just to note that tricuspid stenosis is usually rheumatic in origin. It usually does not occur as an isolated lesion, but however, accompanies usually rheumatic disease in the left, in this context, the mitral valve disease. And typically, when present, symptoms will include things like right-sided heart failure with hepatomegaly, abdominal swelling due to ascites and anasaka, and then, of course, with fatigue. Also, when these people are auscultated, there usually is a revelation of signs of mitral stenosis. And most often, these overshadow the signs of the tricuspid stenosis. The diastolic murmur of this tricuspid stenosis is best heard along the lower left sternal border at the fourth intercostal space, and usually softer, has a higher pitch, and shorter in duration than the murmur of mitral stenosis. Just to note that for severe tricuspid stenosis, usually for the management is surgical, and it will require valvulotomy or valve replacement if the orifice is less than approximately 2 centimeters square. So in general, tissue valves are usually preferred in the tricuspid position because of the high risk of thrombosis with mechanical prosthesis. Also to note that the most common form of pulmonary stenosis is congenital. In some cases, however, though very rare, they can result from carcinoid plaques. And these carcinoid plaques usually cause constriction of the pulmonic valve ring, retraction, and then fusion of the cords. And this can result in pulmonary stenosis with or without pulmonary regurgitation. Also to note that the carcinoid heart disease can also involve the tricuspid valve, but most commonly leads to tricuspid regurgitation, not stenosis, as in the case presented before us. Also to note that most adults with mild to moderate pulmonary stenosis may be asymptomatic, and it's only the severe forms that result in dyspnea and fatigue. And like we said, patients with advanced pulmonary stenosis may develop secondary tricuspid regurg and right ventricular failure. In majority of patients, valvular PS is stable or a slowly progressive disease. Just to note that most times we tell patients that have valvular conditions probably to breathe in and hold your breath. And we expect that the intensity of the right-sided murmurs will be increased when patients breathe in and hold their breath. And of course, we say breathe out and hold your breath. And we expect that the intensity of the left-sided murmurs will be increased. However, a rule to this exception is in pulmonary stenosis. So the inspiratory increase that we notice in most right-sided cardiac sounds for the PS, the intensity of the pulmonary click decreases with inspiration. And of course, this can be diagnosed by the echocardiography. Basically, that's what we do. And then in adults, percutaneous balloon valvuloplasty for advanced valvular PS is safe and effective method of treatment. Now, going back to the question, like we said initially, match each description with the associated condition. We talked about TS, PS, both, neither. So the first question, 581, usually rheumatic in origin. Which of these is usually rheumatic in origin? Of course, the answer here is the tricuspid stenosis, just like we explained when we were doing a rundown of this condition. Which of these is typical of carcinoid heart disease? Is the pulmonic stenosis, so that answer is B. Most adults are asymptomatic. Of course, in mild and moderate PS, usually present with no symptoms. So the answer for that is B, which is pulmonic stenosis. Ascites is common on physical examination. The answer will be tricuspid stenosis, which is a common cause of right-sided failure. And we see anasaka and ascites. We see all those features. And so we expect to see that in TS, tricuspid stenosis. Balloon valvuloplasty is the treatment of choice. We expect that modality in pulmonic stenosis. So the answer is B. And that is the end of my presentation. Thank you very much.
All right, thank you, Dr. Ovunda. Thank you. Excellent presentation as always. We'll move to Dr. Freedom. Dr. Freedom, are you available? Dr. Freedom, are you here with us? That's 612.
Sorry, I'm here. Sorry, I'm here. I went to my log off and
All right. So,
I'm just
all right, excellent. So let me go to your own section. All right, so over to you, sir.
okay. Hold on. Let me just settle in a bit. Okay. Thank you. Okay. Good evening, consultants, fellows, and colleagues. I'm taking questions 612 to 619. Right? I'm correct. 612 to 619. Yes, 612 to 619. So the question says match each photograph in figure 4.33 with the condition it represents. A is part A, B is part B, C is part C. Please, can we go to figure 4.33? Okay, this figure 4.33, I think for part A, it's showing us, I'm not seeing it in full though. Okay, these are the pictures. Part A is showing us a lesion on the plantar surface of the big toe. Then part B is showing us the tongue of a patient being very beefy and large. Part C is showing us tortuous vessels on the conjunctivas of the eyes. Then part C is showing us the hand of a patient with some lesions on the distal with some pinkish lesions on the distal and proximal part of the palmar surface of the hand. Then the hand is looking also flexed. Then I think we can also see some lesions at the tip of the fingers. So let's go to the options to see. Dr. Eugene. Hello. Okay. 6122. That's 612. Okay. Okay. For 612, the conditions that are stated there are Fabry's disease, infective endocarditis, amyloidosis, systemic sclerosis. Fabry's disease, infective endocarditis, amyloidosis, and systemic sclerosis. So for infective endocarditis, I think we have so much discussions on that while answering our questions. Even we had a curriculum presentation on infective endocarditis where we talked about the extracardiac manifestations of systemic endocarditis, which includes the presence of skin lesions such as petechia, the presence of ulnar nodes, Chinway lesions, rod spots, and sphincter hemorrhages, and presence of embolic impact of the digits. What we are seeing in one of those figures there, I think that's figure part C. Part C. Oh, okay, 612. Okay. As part A now is actually looking like it's a Janeway lesions that we see in patients with infective endocarditis. That's one of the extra cardiac manifestations of infective endocarditis. Janeway lesions are usually described as small, irregular, flat, and non-tender macros, occurring most often on the tender and hypotender eminences of the hands and feet. And they have some similarity with ulnar nodules. However, there's some differences. Unlike Janeway lesions, which are painless lesions, ulnar nodules are small, raised, nodular, and painful red to purplish lesions that appears in the pulse spaces of the terminal phalanges of the fingers. Other extracardiac manifestations of infective endocarditis include the presence of rod spots, which are usually seen on the retina, and they have the appearance of cotton wool exudates as seen in patients with diabetic retinopathy. And they're also seen as connections of aggregates of cytoid bodies on the retina. Then, so for question, so this part, that's part A now, is showing us Janeway lesions that we see in patients with infective endocarditis. So for that infective endocarditis, the answer to that is part A, Janeway lesions, which is one of the extra cardiac manifestations that we see in patients with infective endocarditis. Then for part B is macroglossia with the deposition of amyloid tissues in the tongue. Okay. Macroglossia with the deposition of amyloid tissue in the tongue, which is seen in patients with amyloidosis. As the last presenter just mentioned something about amyloidosis. In addition to that, I would say amyloidosis is a systemic illness or a group of diseases characterized by the accumulation of amyloid tissues, amyloid deposits in various organs and tissues of the body, leading to disruption of leading to damage and disruption of the normal organ function. We have different types of amyloidosis. We have the primary amyloidosis, secondary amyloidosis. The primary amyloidosis is usually caused by presence of plasma cells, as seen in patients with multiple myeloma. Secondary amyloidosis is associated with chronic inflammatory diseases such as rheumatoid arthritis. There's also the familial amyloidosis, in which there is genetic mutations in the transthyretin gene. This familial amyloidosis has the white type and it has the white type. It has another type of transthyretin amyloidosis. That's the white type, which occurs, is seen in adults and also affects the heart. There's also dialysis-related amyloidosis, which is associated with patients, renal patients, that CKD patients having um, usually end-stage renal disease patients that are on dialysis, maintenance dialysis. The symptoms of amyloidosis includes fatigue, weight loss, swollen legs and ankles, vomiting. You can have abnormal heart readings. Some of them can have diarrhea, and they can also have macroglossia, as I mentioned earlier, from deposition of amyloid tissues, amyloid deposits rather, amyloid deposits in the tongue. Other cardiac sequelae for associated with amyloidosis includes cardiomyopathy. They will have diastolic and systolic dysfunction. They also have conduction and abnormalities. So for Part B is showing a patient with deposition of amyloid deposits in the tongue. The patient has macroglossia. So Part B is showing us a patient with one of the clinical presentations of amyloidosis. Okay. Then, okay. Then for Part D is showing us a common finding that we see in patients uh, with progressive systemic sclerosis. Patient progressive systemic sclerosis usually presents with tightening of the skin and thickening of the skin with Raynaud phenomenon. As we know, Raynaud phenomenon can be primary and secondary. Secondary Raynaud phenomenon is when the Raynaud phenomenon occurs due to another medical condition. And usually Raynaud phenomenon is characterized by narrowing of blood vessels in response to cold temperatures or stress, and there is acetate color changes, usually change color to white, pale, or blue discoloration. Like I said, for primary Raynaud phenomenon, there is no underlying medical condition. For secondary Raynaud phenomenon, there is associated underlying medical conditions such as scleroderma, as you can see for these patients, lupus, systemic lupus erythematosus, rheumatoid arthritis, and the cardiac involvement is the commonest finding in patients with systemic sclerosis, and this is second only to patients having renal. The commonest involvement in patients with systemic sclerosis is cardiac involvement. Commonest, uh, sorry, cardiac involvement is common, second only to renal involvement. Then scleroderma heart disease is a myocardial process that occurs due to vascular insufficiency and fibrosis in small vessels of the heart, which leads to cardiomyopathy, and the patient can end up with signs and symptoms of heart failure, and they can also have conduction and ventricular arrhythmias. So for Part D, it's showing us a patient with key manifestation of progressive systemic sclerosis. So for Part D, I don't know the option that is related to that now. But for Part D, is progressive systemic sclerosis. That's 615 is Part D. That's D is the answer for 615. For 615, the answer is D. Okay. I think the next Hello? Hello?
Yeah, hello, can hear you. Charles is
Yes, we can hear you. Are you done with the question? Hello, Dr. Freedom.
Hello?
Yeah, we can hear you. We can hear you.
Hello? Hello, can you hear me?
Yeah, we can hear you.
Oh, okay, sorry, I was off. The network
All right.
went off for some time. So for part B, is showing presence of tortuous vessels in the conjunctiva. This is usually a finding seen in patients with Fabry's disease. And Fabry's disease is a sex-linked disorder that is due to a deficiency of the enzyme alpha galactosidase and is characterized by the accumulation of glycosphingolipids within the myocardium, the skin, and the kidneys. Common clinical manifestations of Fabry's disease includes presence of systemic hypertension, mitral valve prolapse, and present with signs and symptoms of heart failure. And Fabry disease can also cause restrictive cardiomyopathy. 90% of patients with Fabry disease have corneal opacities, and two-thirds of them have tortuous vessels in their conjunctiva, as seen in these patients. The causes of death in patients with Fabry disease includes hypertension, cerebrovascular accidents, and renal failure. So for Fabry disease in the option, the part C corresponds to tortuous vessels seen in conjunctival patients with Fabry disease. So for question 612 to 615, the answers are 612 is C, 613 is A, 614 is B, and 615 is D. So CABD. CABD. So if there are contributions or questions, you can ask. Otherwise, I'll move to the next question because I'm to continue with 616 to 619. For 616 and 619, they said we should match the following descriptions with appropriate associations. For A, Turner syndrome, B, Noonan syndrome, C, both, D, neither. So 616, so which of them presents with coarctation of the aorta? Which of them has coarctation of the aorta as a feature? For 617, which one has normal karyotype? 618, which one has um, pulmonic stenosis on echocardiography? 619, which of these conditions, either one of them or both of them, which has short stature, webbed neck, skeletal anomalies, and renal anomalies? So we'll just give a brief rundown of Turner syndrome. Turner syndrome is one of the most common congenital anomalies. It occurs in about 1 in 2,000 life um, born female infants. It's caused by um, a missing or it's caused by either a missing or partially deleted part of chromosome X. It can be caused by a monosomy in which one X chromosome is missing, and also be caused by mosaicism in which the patient has the karyotype of 46XX and 45XY. Then can also be caused by a deletion of a part of the X chromosome. They have multiple presentations. They present with webbed neck, short stature, delayed puberty. They also have features of cardiac conditions such as coarctation of the aorta by bicuspid aortic valve. They can also present with features of upper GI bleeding because they usually have vascular malformations, can have scoliosis. They have high arched palates, and they also have short, fourth, and fifth metacarpal metacarpal. Some of them can also present with behavioral anomaly. Okay. They also have infertility from ovarian dysfunction. They have kidney problems. They also have learning disability. They usually have problem with mathematics, reading, and writing. You can also present with features of ADHD, attention deficit hyperactivity disorder, and depression. Then for Noonan syndrome, in diagnosing them, essentially you can do karyotyping, you can do physical examination to look out for the characteristics I just mentioned. You can also do imaging studies in which we look out for the renal anomaly, presence of bicuspid aortic valve or coarctation from your echo. Then in managing them, you can do hormonal therapy, can do hormone replacement in patients. For those patients with that have delayed puberty, can do hormone replacement. For those that have short stature, can do growth hormone replacements. Then can do surgery to repair heart defects. Then can also do speech and language therapy, occupational therapy, and psychological counseling for them. For Noonan syndrome is actually has features that are similar to Turner syndrome that affected patients that are affected with Noonan syndrome usually have unique facial appearance with hypertelorism, strabismus, can have low set ears, is usually inherited as autosomal dominant traits, and it's seen in both sexes, unlike Turner syndrome, which is commoner in female, which is seen in only females. The karyotypes in both sexes are normal for Noonan syndrome, unlike patients with Turner syndrome, where we see abnormality in their karyotypes. Then usually due to mutations in several genes, but commonly is due to mutation in patients with PTP N11 gene. Other mutations that can be seen in patients with Noonan syndrome includes SHOC2 gene, SOS2 gene, KRAX, KRAS gene, and RAS gene, then CBL gene. 50% of them usually have congenital heart diseases. The most common form of congenital heart condition that is seen in them is pulmonary valve stenosis, seen in about 60% of patients with Noonan syndrome. Other findings include atrial septal defects. They can have hypertrophic cardiomyopathy. The symptoms are essentially the same. However, for Noonan syndrome, they usually have left-sided heart lesions like pulmonary valve stenosis. They can also have atrial septal defects and ventricular septal defects. Now, I mentioned earlier that for patients with Turner syndrome, they usually have coarctation of the aorta, that also presents with bicuspid aortic valve. Other symptoms or presentations that we can see in patients with Noonan syndrome include developmental delay, like I mentioned earlier, for patients with Turner syndrome. They can also have ADHD, anxiety, depression. They can have bleeding tendencies. There are some common findings in patients with both Noonan and Turner syndrome. Patients with Noonan syndrome have web neck, like patients with Turner syndrome. They can have low set ears, like that is also seen in patients with Turner syndrome. Both of them have pedal edema. However, pedal edema is commoner in patients with Turner syndrome. They have white space nipples, which is seen in both conditions. In both two, also have short stature, and both of them have congenital heart defects. However, like I said, for Noonan syndrome, pulmonary stenosis is common, while for Turner syndrome, they have bicuspid aortic valve, coarctation of the aorta. Then both of them for Noonan syndrome, as I also mentioned earlier, it affects both male and female. Right? Turner syndrome is seen only in females. And in Turner syndrome is not usually inherited. And they have amenorrhea. That's one of the causes of infertility in them. So we'll go back to the question. So the question is that we should match the following descriptions with appropriate associations. To match the following symptoms with appropriate associations. Okay. So for Turner syndrome, that's coarctation of the aorta. I mentioned earlier that coarctation of the aorta and bicuspid aortic valve is seen in patients with Turner syndrome. So that's one of the congenital heart diseases that we see in patients with Turner syndrome. So question 616, the answer is A. Then for question 617, which of them has normal karyotype? Like I said, patients with Turner syndrome have abnormal karyotype. However, for Noonan syndrome, they usually have normal karyotype. So for 617, the answer is B. Noonan syndrome patients have normal karyotype. Then 618, in which of these two conditions do you see pulmonary stenosis? I mentioned earlier that for Noonan syndrome, we see pulmonary stenosis. They can also have ASD and PSD. So for 618, pulmonary stenosis is usually seen in patients with Noonan syndrome. So 618 is B. Then for 619, okay, that is 617. Okay, 619. Which of the conditions are associated with short stature, Webb's neck, skeletal anomalies, and renal anomalies? I mentioned earlier that this can be seen. In actually both conditions. You have short stature, Webb's neck, skeletal abnormalities, and renal anomaly. You can see in both Noonan syndrome and Turner syndrome. So for 619, the answer is C. You can see in both. So for question 616 to 619, 616 is coarctation of the aorta, which is seen in patients with Turner syndrome in addition to bicuspid aortic valve, like I mentioned earlier. Then 617 is Noonan syndrome that has the normal karyotype. Turner syndrome I mentioned earlier has several karyotypes that I mentioned before. Then 619, patients with Noonan syndrome and Turner syndrome usually present with short stature, Webb's neck, skeletal anomalies, and renal anomalies. So that's the end of my question. If there are comments and questions, I can take at this point. Thank you. Hello.
All right. Thank you, Dr. Freedom. Thank you for taking your part so well. So I believe we've cleared the backlogs. So we'll move over. Yeah,
So,
Eugene.
I think there's another backlog. Let me check. Maybe I'm getting it wrong. Just a second. Because I have here in red. Did Dr. Mojid do his?
Yes, he did.
Oh, okay. All right. Please, you can continue.
All right, thank you. Yeah, it's like someone wants to say something. All right, so we're going to go to Dr. Sorry, I didn't know I was muted. I said we're going to go to Dr. Ayodeji. After that, Dr. Ayodeji. After that, Dr. Olarewaju. After that, Dr. Asore. So that's how we move. So, Dr. Ayodeji, are you around, sir? Hello, Dr. Ayodeji. Is he? Are
Is it
you in
Adedeji or
class?
Ayodeji?
Eh, Is it? Let me. I think it's a mistake. No. Dr. Adedeji presented yesterday now.
I've done my, but there is a way they wrote that name. They took part of my name and joined to the next one. I don't know whether that was the way the mistake is.
Okay, I get your point.
And part of my name is they shifted it to the next person after.
Sutured your name. So sorry about that. Let me just check it. Just 1 minute.
Hello, Charles.
Yeah, Eugene. Yeah.
I've posted it in the chat box.
Is the chat box? It seems like there is like we've done 567 to 575. Where we stopped actually is we're supposed to start from 620.
Okay, so
620 to 629. We've done all the numbers before this one.
So 620 is Dr. Aniedi Kenneth.
No, Dr.
620.
Kenneth. No, Dr. Kenneth took her own
Okay,
yesterday.
so Ibitoye Ayodeji, 630.
Yes.
Oh.
Okay. 630. Sorry.
Then Ola Uju Abdulaziz, 635 to 669. Then Dr. Sorry. Then Dr. Chineme, but Chineme has been called for a case. Then Oji Miriam. She also said she was struggling with network. I don't know whether she's on now, but at least Dr. Yudeji, Abdulaziz, and Asor.
Okay. So, Doctor, let me check if Dr. Ayodeji is in class. I prefer we go without missing so much. Okay, it seems not to be in class. Dr. Olariwaju, I don't know if you can take yours now. Dr. Olariwaju. Dr. Sore. Dr. Sore in class. Yes, not in class. Right. Okay. Okay, Chineme is not around. Dr. Miriam Oji. Okay, I'm not sure she's around.
Olaiwaju is in class. I'm trying to unmute.
Okay, Olariwaju, thank you. All right, so we'll take yours now. Okay. So that's 635.
Here, and as I shared with you previously in great detail.
Okay, I will be taking question 635 and those doors. A 58-year-old woman in good health presents for evaluation. She is concerned about cardiovascular risk because her father suffered MI at age 70 years. Which of the following statements about health disease in women is not correct. A, cardiovascular disease is the leading cause of death in women. B, premature menopause is a risk factor for cardiovascular disease in women. C, coronary heart disease presents approximately 10 years later in women than in men. D, diabetes mellitus confers general risks for coronary heart disease in men than in women. And E, hormone replacement therapy with estrogen does not reduce the risk of cardiac event in postmenopausal women. So this question is about cardiovascular disease in women. And considering the options given, it has been shown that cardiovascular disease is the major cause of mortality in women. And apart from that, in the United States, it has said to be accounting for 1 in 4 deaths. And also, coronary heart disease usually presents about 10 years later in women than in men. It still looks to be applicable to what is being observed in women as regards to something like hypertension and including even stroke. We realize that men have the higher prevalence of developing this particular disease. However, due to the protective factor of estrogen, it has been reported that women later develop it, particularly when they clock menopause. That's when it places with that of men. And using this particular preface, we can now say that coronary heart disease usually presents in women some years for what has been given like 10 years later than in men. And it usually occurs after menopause. So there's a particular study that is called inter-heart study. This also demonstrates that the pattern is widely consistent across the world. So it's not only limited to a particular race. The age difference may be contributed by the protective effects of estrogen, as I've said earlier. And also, despite the fact that it was being attributed to absence of presence of estrogen to serve as a protective factor prior to the commencement of menopause, it has also been shown that some women that develop premature menopause are associated with a higher risk of cardiovascular disease, irrespective of if exogenous estrogen is being given to them. This does not correct this particular effect. Also, these and the other risk factors like dyslipidemia, hypertension, tobacco use, diabetes, obesity, and sedentary lifestyle. All this has been attributed to be part of the modifiable risk factors that contribute to heart disease in women. And diabetes have been reported to confer a greater risk to coronary heart disease in women than in men. And this increasing a woman's risk of coronary heart disease likewise from about 3 to 7-fold compared to that of the male counterpart, which is just about 2 to 3-fold. So going back to the question, hope I'm still audible.
Yes, you're audible.
All right, thanks. So going back to the question, cardiovascular The question is that which one is not correct? So cardiovascular disease is the leading cause of death in women. This is correct, as this has been confirmed that the most common deaths are the number one cause of mortality in women is cardiovascular disease. The next one is premature menopause is a risk factor for cardiovascular disease in women. This is also correct, so it's not part of the not correct option. Next one is coronary heart disease present approximately 10 years later in women than in men. This has been said earlier that male normally have coronary heart disease before female due to the estrogen factor. The next one is DM confers greater risk for coronary heart disease in men than in women. This is not correct because based on what was said before, it is more common in women. Women with diabetes, they have higher risk of having coronary heart disease compared to that of men, although what is responsible is not being explained. And looking at the last option, hormone replacement therapy with estrogen does not reduce the risk of cardiac events in a postmenopausal women. This option is a statement of fact and it won't be the correct answer. So of all the options given, it is D that is incorrect due to the fact that DM confirms a greater risk for coronary heart disease in women than in men. But this has been swapped to be in men than in women. Other options that were given there were statement of facts, but the only incorrect one is the D. Should I go on or we have something we need to contribute? Okay, for question 636, is a 36-year-old woman with no prior history of cardiac disease develops exertional dyspnea and orthopnea 1 month after delivering a healthy full-term infant. Echocardiography demonstrates a dilated left ventricle with globally reduced systolic function. Which of the following statements regarding PPCM is true? A, PPCM is most often diagnosed prior to delivery. B, there is a shared genetic predisposition to some PPCM cases and other forms of dilated cardiomyopathy. C, the incidence of PPCM is highest in the first pregnancies. D, approximately 10% of patients with PPCM show recovery within the first 6 months after delivery. And E, younger maternal age is a risk factor for PPCM. You know that from this scenario, though the question is much on PPCM, because looking at this scenario, realize that a patient that is 36-year-old without prior history of cardiac disease develops symptoms of heart failure, and it happened after 1 month delivery of a healthy full-term infant. And still confirming with echo, it shows dilated cardiomyopathy. So giving a little background on PPCM, we know that it's a diagnosis of exclusion. After we've ruled out other cardiac cause, so other heart diseases such as hypertensive heart disease and dilated cardiomyopathy, and ischemic heart disease, valvular heart disease. We can see from the history that is being given that this patient is previously healthy without any cardiovascular issue. So meaning that this has been ruled out already. And looking at the duration too, it has been said that it's between the last month of pregnancy to about 5 months after delivery. Some extend it to about 6 months after delivery when patients develop symptoms that mimic or that is similar to that of dilated cardiomyopathy. So this makes the patient to still fall under the window of PPCM. Then PPCM is a form of dilated cardiomyopathy that may occur de novo in the context of pregnancy. And as I said, it's between the last month of pregnancy to about 5 months post-delivery. However, it is said to be most commonly diagnosed 4 months after delivery. That's when it is most common based on studies or epidemiological studies. That doesn't mean that we didn't see some a month prior to delivery or even within our first, second, or third month after delivery. The most common presentation is about 4 months after delivery. And when identified during delivery, it is usually during pregnancy, it is usually during the final month of gestation. And that's one of those things that is used as the definition of PPCM. So although traditionally viewed as an entity that is distinct from other forms of dilated cardiomyopathy, but there are evidence that shows a significant overlap in the genetic predisposition to PPCM and other forms of dilated cardiomyopathy. So despite the fact that we are saying that it is diagnosis of exclusion, there is still a correlation or a relationship in terms of genetic predisposition between PPCM and other forms of dilated cardiomyopathy. So the incidence varies by geographic region. And I think with the latest study that was done, I think it's in Kano, that's where we have the highest number of PPCM worldwide. And it has been estimated to be between 1 in 1,000 and 1 in 3,200 live deaths. So risk factors for its occurrence include multiparity, old maternal age, preeclampsia, American race. Although before we do say that hot baths do contribute, and also this cow that people in the north do contribute. But the latest study ruled all those ones out and saying that it is not part of those things that should really be considered as the risk factors. So approximately 50% of patients with PPCM shows complete or near complete left ventricular recovery. This is one of the cardiomyopathy that patients can really recover fully. However, about 50% may have their systolic dysfunction or continue to deteriorate. And that's the reason why issues concerning getting pregnant after PPCM is subjected to the improvement in ejection fraction. There are still some school of thought that say despite the fact that ejection fraction is improved, there is possibility of patients going back to the previous state if care is not taken. So this have to be put into consideration to as per concerning how long should a patient with PPCM have another pregnancy. There is no a generalized consensus on that particular issue because patient also responds differently. So apart from that, Yeah, yeah. Apart from that, too, it is also being discovered that about 30% of patients have risk of experiencing relapse, despite the fact that they have normal EF following their treatment with PPCM. So going back to the question now, PPCM is the most often diagnosed prior to delivery. This is wrong. It would be diagnosed prior to delivery, but that's not the most common time that it is being diagnosed. B, there is a shared genetic predisposition in to some PPCM cases and other forms of dilated cardiomyopathy. This is actually correct. But because it is best of 5, we don't know if we can still have a better option than this particular one. C, the incidence of PPCM is highest in the first pregnancy. This is actually wrong. It is multi-parity, and also in terms of age, older age also contributes to the incident. But the incident here is more with multi-parity, not with first pregnancy. Approximately 10% of patients with PPCM show recovery within the first 6 months after delivery. This is incorrect because it's about 50% that shows recovery after delivery. And also, younger maternal age is a risk factor for PPCM. This is also wrong. So looking at all the options given, the best answer here is option B. So I don't know if we have any other thing to add based on this question, because we have a lot on PPCM, but just to limit ourselves to the questions that were being asked. So contributions, or we should go ahead.
Hello, Dr. Larwadi. Sorry, thanks for the this presentation. You said if the incidence is higher in Kano, I don't know if there's any particular reason for that.
Yes, I said the incident is highest in Kano. I think there is Professor Kati. This is Professor, I want to remember the professor in Kano. The cardio. Can someone
Hello,
remember?
can I,
Professor Karaye.
Professor Karai?
Karaye, yeah,
Karaye.
Professor Karaye.
Okay.
Yeah. So we need to look at this thing, but that's the highest and is the
I
one
think,
that is highest. Yeah.
can I contribute? I think it's not
Yeah,
like the incidence is highest in Kano. It's just that it has been studied more in the northern states. So it's not like there are comparisons with other southern states to particularly say it's higher. It was earlier studied in Zaria, then subsequently Professor Gare studied in Kano. So these are studies that one can make reference to in particular.
Yes, thank you for that. There are still some people that are going against that particular study, but I remember it maybe during the last NCS or so far, Professor Mbakwe raised an issue that so far that is the largest study that has been done on PPCM, and it still needs to be accepted, not even saying because it has not been compared with the other states that should be a reason why they can be bringing the shortcomings or pitfalls for that particular study. I don't know if any of us have something else to say on it. Hello? Am I audible?
Yeah, you're audible. I think you can continue.
Yes, you're audible.
All right, thank you for your contribution. So the next question is question 637. So for 637, it reads thus. A 67-year-old man with multivessel coronary disease is scheduled for CABG surgery. Which of the following statements regarding CABG and perioperative complication is correct? A, In-hospital mortality after isolated CABG has increased over the past 2 decades because of the increased complexity of cases for which the procedure is used. B, short-term post-operative cognitive decline occurs in less than 10% of patients after CABG surgery. C, atrial fibrillation appears in up to 40% of patients after CABG surgery. D, of patients who develop postoperative AFib, only 20% will spontaneously revert to sinus rhythm within 24 hours. And lastly, N-acetylcysteine prevents renal dysfunction after CABG. So this particular question is testing us on CABG and the outcome in terms of perioperative complication. And it has been shown that the frequency of perioperative complication in CABG increased because of the greater percentage of high-risk patients who undergo the operation. We know that before CABG could be what to be decided on, there are some other factors that have to be considered before it now gets to the last option of going for CABG. And we know that the other interventional procedure for some cases take precedence over CABG. However, in some cases whereby the interventional will not suffice, like multivessel disease in patients that even have comorbidity like diabetes, you know that CABG has been said to be superior to it is a class 1 recommendation, and there are others like that. So due to the complexity too, there are things like expertise, centers, and the complexity and comorbidity of the cases that have to be considered so that the morbidity or the outcome will not be fatal. So, however, due to the high risk or the complexity of this procedure, it has been shown that the perioperative complication has really actually increased. However, in-hospital mortality after isolated CABG has declined, and this was reported to be from 3% in 1997 to about 2% in 2015. And the reported incident of perioperative MI also varies with a median of 2.9%. So in terms of stroke or cerebrovascular complication, this has also been reported to occur after cardiac surgery by mechanism such as atherosclerotic cerebral emboli, which may come up from the aorta, or emboli related to cardiopulmonary bypass machine, or from intraoperative hypotension or hypoperfusion. So there are some studies that have also revealed that a post-cardiac surgical incidence of stroke range from 1.5% to about 5%. And the short-term cognitive decline has also been identified in more than 50% of patients at the time of discharge. So, another important point based on the question that was raised and options given is that AFib has been shown to be one of the most frequent complications of CABG. And this developed in up to 40% of patients within 3 days after surgery. And it is associated with about 2 to 3-fold higher risk of postoperative stroke. And up to 80% of patients spontaneously revert to sinus rhythm within 24 hours without treatment other than rate control agents. Also, prophylactic beta blocker or amiodarone has also been confirmed to reduce the occurrence of postoperative AFib. And the incidence of renal failure requiring dialysis after CABG is very low, about 0.5 to 1%. But it is associated with greater morbidity and mortality when it occurs. And there's no positive impact that N-acetylcysteine can do to prevent renal dysfunction from occurring after CABG. So going to the question back, in-hospital mortality after isolated CABG has increased over the past 2 decades because of the increased complexity of cases for which the procedure is used. This one is incorrect. Short-term post-operative cognitive decline occurs in less than 10% of patients after CABG. This is also incorrect. It's more than 50%. Also, atrial fibrillation appears in up to 40% of patients after CABG surgery. This is correct. Of patients who develop postoperative AFib, only 20% will spontaneously revert to sinus rhythm within 24 hours. This is incorrect. It's up to 80%. N-acetylcysteine prevents renal dysfunction after CABG. Despite the fact that patients do develop renal dysfunction after CABG, N-acetylcysteine do not have anything to do to preventing renal dysfunction after CABG. So from these options, it is C that is very, very correct, which is atrial fibrillation appears in up to 40% of patients after CABG surgery. Any contributions, sir? So going to 38, please can you help me to show up if we don't have contributions from that? A 70-year-old man is a 70-year-old man undergoes coronary artery bypass grafts without complications. At the first post-operative office visit, he reports resolution of his angina symptoms and asks how long the benefit will last. Which of the following statements regarding CABG surgery is true? A, fewer than 2% of saphenous vein grafts become occluded in the early perioperative period. B, internal mammary artery graft typically develops intimal hyperplasia over time. C, saphenous vein grafts have a 10-year patency rate greater than 75%. D, radial artery grafts are less likely to develop vasospasm than internal mammary gland grafts. And E, patients who receive internal mammary artery grafts suffer fewer late deaths and myocardial infarction than those who receive only saphenous vein grafts. So this particular question is just trying to test which of the grafts will last longer and will give a good outcome following CABG. So there are various grafts that have been used during CABG. And one of those grafts include graft from saphenous vein, also graft from internal mammary artery, radius artery. These are different grafts that has been employed during CABG, but these three grafts have their own pros and cons. However, considering that of saphenous vein, it has been confirmed that it is easy to harvest, but they have several setbacks. And approximately about 8 to 12% of saphenous vein graft becomes occluded during the early perioperative period. And it has been shown that by 1 year, about 45 to 30% of the vein grafts become occluded. And some of the occlusion may be due to endothelial thinning during surgical preparation, thereby predisposing the grafts to early thrombosis. So what this is just saying is that despite the fact that saphenous vein is easier to harvest, part of the setback is that it's occludes on time. Within a year, it's about 30% get occluded just within a year. And this is not so good for a long-term effect for whosoever undergo that particular procedure. However, for internal mammary artery, although it is said to be difficult to be harvested, but these do not develop internal hyperplasia, and it also has about 10 years patency rate, which is greater than 80% compared to the one that is just by 1 year, and this thing is just about 30%. So this confer a better outcome compared to the saphenous vein. And there are some explanations for the superiority of this intermammary artery graft for it being used. The first one is due to the medial layer of the arterial graft may derive additional nourishment from another vessel close to it, which is the vasa vasorum. Secondly, the endothelium of the intermammary artery produces high levels of endogenous vasodilators like the NO, making it to get relaxed and prevent it from getting thrombosed. Thirdly, is the diameter of the internal mammary artery is closer to that of the recipient coronary artery. And due to these two, it makes it to be better than saphenous vein. Now, the last one is the radial artery, which is also being used. However, it is not as used as the other two. Although it can also give good outcome, but its own drawback is that it develops vasospasm, and that is just its own setback. It can also serve as effective conduit with high long-term patency. However, vasospasm is a major challenge in this particular graft. So going back to the question, A, fewer than 2% of saphenous vein grafts become occluded in the early perioperative period. This is very wrong. It is up to 30%. B, internal mammary artery grafts typically develop intimal hyperplasia over time. This is also wrong. C, saphenous vein grafts have a 10-year patency rate of more than 75%. This is wrong, as it is for internal mammary artery, and that is even more than 80%. D, radial artery grafts are less likely to develop vasospasm than internal mammary graft. This is also incorrect, because the major setback for radial artery is vasospasm. E, patients who received internal mammary artery grafts suffer fewer late deaths and myocardial infarction than those that receive only intravenous vein graft. This is very correct, making option E to be the correct answer in this particular case. Any contribution, addition, comments? We're going to question 639. A previous healthy 17-year-old high school athlete collapses during a basketball game. He is noted to have brief seizure-like activity and has no initial pulse. Prompt bystander CPR is initiated and an automatic external defibrillator is applied to his chest. Indicating that it is a shockable rhythm. He is defibrillated with immediate return of spontaneous circulation. Which of the following statements is true about sudden cardiac death in young athletes? A, sudden cardiac death in young athletes is always related to underlying structural heart disease. Always related to underlying structural heart disease. B, anomalous origin of the left main coronary artery from the right coronary corpse is the most common of the congenital coronary abnormalities that result in sudden cardiac death in young athletes. C, normal pre-training history and physical examination exclude the possibility of hypertrophic cardiomyopathy. D, patients who experience sudden cardiac death due to hypertrophic cardiomyopathy typically have preceding cardiac symptoms. E, congenital aortic stenosis is the most common structural cause of sudden cardiac death in young athletes. So looking at this question, is telling us, trying to test us on sudden cardiac death in young athletes. So in young athletes, it is said that sudden cardiac death is a rare tragic event. Although we may be looking at it that exercise-related sudden cardiac death has been related or attributed to inherited structural abnormalities such as Ocum and the likes, and anomalous origin of the coronary artery. However, there are some evidence that suggests that about 40% of sudden cardiac death in athletes occur without apparent structural abnormalities, presumably related to arrhythmia. We know other causes of sudden cardiac death. It's just that because it is specific to young athletes here, we know that if we are being asked to list causes of sudden cardiac death, it is not only limited to structural abnormalities. We also have those that are attributable to electrical abnormalities like arrhythmia. The optimal cardiovascular screening strategy in young athletes continue to be debated. So because it is common for sudden cardiac death victims with hypertrophic cardiomyopathy to be asymptomatic throughout their lives, routine history and physical examination before undertaking competitive sports have been said to have missed many cases, because by the time you even screen them and examine them, they will come out to be normal. Since they are not symptomatic, everything looks normal. The most frequent form of anomalous origin of coronary artery is the one that is anomalous origin of the left main coronary artery, which arise from the right coronary corpse. And also opposite can also be seen, whereby we have anomalous origin of the right coronary artery resulting from the left aortic sinus. This has also been reported to be part of causes of sudden cardiac death in young athletes. MI is in individuals with anomalous coronaries may relate to a kinked takeoff of the artery or compression of the vessels between the aorta and the pulmonary trunk during exercise. And as we have hypertrophic cardiomyopathy, coronary anomaly are very difficult to identify by routine screening. So screening patients for this is not really advisable or suggested because it's something that is actually difficult to get. Much less common causes of sudden cardiac death in young athletes include myocarditis, aortic dissection, congenital and arrhythmogenic right ventricular cardiomyopathy. These are also causes of sudden cardiac death in young athletes, but is not as common as seen in anomalous origin of the left coronary artery or as seen in hypertrophic cardiomyopathy. So going back to the question, sudden cardiac death in young athletes is always related to underlying structural heart disease. This is really wrong because of the always that is there. It is not only structural heart disease that can lead to sudden cardiac death in young athletes. Arrhythmias can also cause such. B, anomalous origin of the left main coronary artery from the right coronary corpse is the most common cause of sudden cardiac death in young athletes. Yeah, this is actually correct, but we don't know if we have a better option apart from this. C, normal pre-training history and physical examination exclude the possibility of hypertrophic cardiomyopathy. This is actually wrong because it doesn't, the history or the normal do not really preclude that this will occur. Patients who experience sudden cardiac death due to hypertrophic cardiomyopathy typically have preceding cardiac symptoms. This is wrong because some patients are asymptomatic. We don't know if such will happen. E, congenital aortic stenosis is the most common structural cause of sudden cardiac death in young athletes. This is actually wrong. It's part of the less common causes in addition to myocarditis and aortic dissection. So out of all these options, I think the best of them all is B. Hello?
Yeah, audible.
Yeah, so the best option there is B, which is the anomalous origin in the left main coronary artery from the right coronary corpse, which is the most common congenital coronary abnormalities that lead to sudden cardiac death in young athletes. I think that's the end of my own part. I don't know if we have someone or any contribution to it before another person takes his or her own part. Thank you.
Thank you, Dr. Olayiwaju. Thank you for taking your part. Thank you for doing so extremely well. We'll proceed with Dr. Let me see now. Dr. Sore. You know, Dr. Sore is here. Dr. Chineme took permission. Dr. Miriam or Dr. Faith. Dr. Faith. Dr. Faith Chikan, are you in class?
Hello, good evening. Hello, good evening, everyone.
Good evening.
Okay, my own part is from 6:56 to 6:50, from 6:55 to 6:59. Okay, so please kindly move to 6:55. Hello? Hello, can you hear me?
Yes, you are audible.
Okay, I can't see the questions anymore. Hello, Dr. Curry.
Hello, sorry, let me share for you. What number are you doing?
6:55 to 6:59.
Okay, please go ahead.
So sorry, I got logged out by network, but you can continue.
Hello? Please go ahead. Hello? Hello,
Hello, can you hear me?
yeah, we can.
6:55, please.
Is it 6:55?
Question 6:55, yes.
Okay. I'm at 6:55. If I move up, it will ban the show. When you start reading, I'll continue.
Okay, a 27-year-old woman undergoes right heart catheterization for the assessment of suspected pulmonary arterial hypertension. The mean pulmonary arterial pressure, can you please move? The mean pulmonary arterial pressure is, hello, you cut the upper part. Is 44 millimeters of mercury, and the pulmonary capillary wedge pressure is 11 millimeters of mercury. Infusion of epoprostenol reduces the mean pulmonary arterial pressure to 31 millimeters of mercury. with no significant change in cardiac output or pulmonary capillary wedge pressure. Which of the following statements is not correct? A. Both intravenous adenosine and inhaled nitric oxide are alternative useful agents to assess vessel reactivity. B. The observed drop in mean pulmonary arterial pressure is predictive of a favorable response to oral calcium channel blockers. C. The failure of the systemic blood pressure to decline suggests that the vasodilator challenge was ineffective. D. Very high doses of chronic calcium channel blocker therapy would likely be necessary to realize full clinical benefits. E. A rise in pulmonary capillary wedge pressure in response to vasodilator therapy will be of concern for impending left ventricular failure. Okay, right heart catheterization is one of the investigations that is done to evaluate patients with pulmonary hypertension. It helps in the diagnosis, classification, and even to guide treatment selection in these patients. According to the World Symposium of Pulmonary Hypertension, you have 5 classes. Group 1, that is those that have pulmonary arterial hypertension. Group B, pulmonary hypertension secondary to left heart disease. Group 2, pulmonary hypertension secondary to left heart disease. Group 3, pulmonary hypertension secondary to diseases of the lungs like COPD. Group 4, the pulmonary hypertension secondary to thrombotic diseases affecting the vessels and the lungs, affecting the vessels such as chronic thromboembolic pulmonary hypertension. Then you have group 5, the one that can be caused by multiple etiology, other unknown causes, and all that. So for pulmonary arterial hypertension, that's group 1. You have the classification using the pulmonary, you can classify it into precapillary or postcapillary, whereby the pulmonary arterial wedge pressure, if it is less than 15 millimeters of mercury, is said to be precapillary, while if it is more than 15 millimeters of mercury, it can be said to be postcapillary. That is the one that's associated with left heart disease. So for pulmonary arterial hypertension, that's the group 1, you have a vessel reactivity testing, which is a diagnostic maneuver that helps to guide therapy in these patients. This testing can be done using some agents like inhaled nitric oxide, IV adenosine, IV epoprostenol, like in the index question, or inhaled iloprost. When you have a positive test, it shows that the patient will benefit.
Move your singlets.
When you have a positive test, a positive vessel reactivity test, it shows that the patient will benefit from calcium channel blockers. And a positive test means when you have more than 10 millimeters decrease in mean pulmonary arterial pressure to an absolute mean value of less than 40 millimeters of mercury without a decline in the cardiac output or a rise in pulmonary capillary wedge pressure. So these patients, like I said, will benefit from oral calcium channel blockers, and of which high doses are generally required for effective treatment. A mean capillary, an increase in the pulmonary capillary wedge pressure during this testing would suggest that you have a pulmonary hypertension as a result of veno-occlusive diseases or impending left ventricular failure. So if we are to go back to the question, the options, we are looking for the one that is not correct. So option A said both intravenous adenosine and inhaled nitric oxide are alternative useful agents to assess vessel reactivity. This is a true statement. Option B, the observed drop in mean pulmonary arterial pressure is predictive of a favorable response to oral calcium channel blockers. This is also a true statement. Like I said, a positive test is when you have more than 10 millimeters of mercury decrease in mean pulmonary arterial pressure to an absolute mean value of less than 40. In the index case, the mean pulmonary arterial pressure was 44, and after the infusion of epoprostenol, it reduced to 31 millimeters of mercury, which is more than 10 millimeters of mercury decline, and is also less than an absolute value of 40. And there was no significant change in the cardiac output or pulmonary capillary wedge pressure. Okay, option C, the failure of the systemic blood pressure to decline suggests that the vasodilated challenge was ineffective. This is wrong. Option D, very high doses of chronic calcium channel blocker therapy would likely be necessary to realize full clinical benefits. Like I said, yes, positive test result shows that the patient will benefit from calcium channel blockers. Option E, a rise in pulmonary capillary wedge pressure in response to vasodilator therapy will be of concern for impending left ventricular failure. This is also a true statement, like I've said before. So the answer to this question is C. That is the option that is not correct. Hello? Can I go ahead to the next question?
Please go ahead.
Okay. Question 656. Which of the following interventions has been shown to reduce the incidence of contrast-induced acute kidney injury after coronary angiography in patients with chronic renal insufficiency? A, infusion of 20% mannitol before angiography. B, administration of atrial natriuretic peptide. C, normal saline administration before and after angiography. D, oral administration of N-acetylcysteine. E, low-dose dopamine infusion. Okay, contrast-induced acute kidney injury is suspected when there is a decline in renal function following recent intravenous administration of contrast media for maybe imaging or interventional purposes. According to the Kidney Disease Improving Global Outcome Guidelines of 2012, the definition of this contrast-induced AKI is also done using the usual definition of AKI, whereby you have maybe an absolute increase in the creatinine of more than 0.3 milligram per DL in 24 hours, or when you have a reduction in urine output to less than 0.5 mils per kg per hour over 6 hours in a patient. So, and it's been found that for this contrast-induced AKI, angioplasty and coronary angiography and also angioplasty are more likely to cause contrast-induced AKI than other contrast studies, with an incidence of between 3% to 13%. But in those who already have background renal insufficiency, the incidence of this condition rises to up to 25%. There are risk factors for contrast-induced AKI. They include chronic renal insufficiency, diabetes, nephropathy, intravascular volume depletion like dehydration, renal artery stenosis, concurrent use of agents or nephrotoxic drugs, such as or agents that alter the renal hemodynamics, such as ACE inhibitors, NSAIDs, metformin, and some antiviral agents like foscarnet and acyclovir. So for this contrast-induced AKI, the treatments, there's no definite or specific treatment for that. Instead, it is better prevented. So as much as possible, try to use the smallest volume of contrast agents in patients that have renal in patients with renal insufficiency because of the risk of nephrotoxicity. And remember that the volume of the contrast injected is also related to the increased risk of nephrotoxicity in this patient. So there are interventions that has been done to try to see if it could prevent the development of this contrast-induced AKI. They include intravenous volume expansion with normal salines before and after the procedure. Also, there's also a trial with IV sodium bicarbonate in elective coronary procedures, and there was no difference between the effect you get when you use normal saline compared to when you also use the sodium bicarbonate. So either of them can be used. Also, there are agents that have been tried, but were found not to be useful, such as use of mannitol, N-acetylcysteine, dopamine infusion, and use of natriuretic peptide and all that. From studies that were done, they were said they were not found to be useful in prevention of this renal complication. So if you're to go back to the question, the options again, they include, remember, we are looking for the one that is correct. A, infusion of 20% mannitol before angiography. This is a false statement because it is not found to be useful in preventing contrast-induced AKI. B option, administration of natriuretic peptide. This is also a false statement because it's not also useful. Option C, normal saline administration before and after angiography. This is a true statement. It is from studies done. It shows that it prevents development of contrast-induced AKI. D option, oral administration of N-acetylcysteine. From large randomized studies done, they were not found to, from small studies that were done initially, it showed them a promising results in preventing contrast-induced AKI, but from further studies that were done with larger number of patients, it could not substantiate the initial finding. Then E, low-dose dopamine infusion. This was also not found to be useful. So for this question 656, the correct answer is option C, normal saline administration before and after angiography. Question 657. A 64-year-old woman presents to her primary care physician with recent fatigue and weight gain. Laboratory evaluation reveals a markedly elevated thyroid-stimulating hormone level. Which of the following is not a common cardiac finding in patients with hypothyroidism? A, hypotension. B, decreased heart rate. C, pericardial effusion. D, decreased cardiac output. E, prolonged QT interval on the electrocardiography. These patients, from the history and evaluation and the lab results shows the patient has hypothyroidism. And then when you have hypothyroidism, there are some cardiovascular changes that occur in patients that have hypothyroidism. These include increased there's reduction in cardiac contractility, increase in systemic vascular resistance. You also have relative bradycardia. So you also have this decreased contractility and the bradycardia. They will lead to reduction in cardiac output. However, when there is hypothyroidism, the effects of a reduction Okay, sorry. Thyroid hormone causes a smooth muscle relaxation, leading to reduction in peripheral vascular resistance. So if you have reduced thyroid hormone in the body, like in this hypothyroidism, the effect of smooth muscle relaxation and reduction in peripheral vascular resistance is lost. So the peripheral vascular tone is going to increase, leading to hypertension, which is common in hypothyroidism. Hypothyroidism can also alter myocardial depolarization, leading to prolonged QT interval. It also causes increased vascular permeability that can be seen in pericardial that can be seen as pericardial effusion, which is relatively common, seen about 1/3 of patients with hypothyroidism. But for it to progress to more complications such as cardiac tamponade is really, really rare. So if you are to go back to the question, option A, hypotension, is a false statement, since this loss of smooth muscle relaxation and decreased peripheral vascular resistance will be lost, leading to hypertension. Option B, decreased heart rate. Like I said before, it causes relative bradycardia. C, pericardial effusion due to increased permeability, vascular permeability. D, decreased cardiac output. Yes, it can cause decreased cardiac output due to the decreased contractility, myocardial contractility plus the relative bradycardia. Since cardiac output is a function of heart rate and
Stroke volume.
stroke volume. Sorry, thank you. Decrease. Option E, prolonged QT interval on the electrocardiography. Yes, this is also correct. It causes prolonged QT interval due to alteration of the myocardial depolarization. Moving on to the question 658. A 28-year-old woman who with Marfan syndrome presents for an office visit. Her echocardiogram shows mitral valve prolapse, an aortic root diameter of 4.5 cm, and mild aortic regurgitation. Which of the following statements regarding cardiovascular disease in patients with Marfan syndrome is not correct? A, some 60 to 80% of patients with Marfan syndrome have mitral valve prolapse on echocardiography. B, the development of aortic regurgitation correlates with the aortic root diameter. C, patients with Marfan syndrome should be considered for elective aortic root replacement once the aortic root diameter excludes 5.5 cm. D, beta blockers should be administered to all patients with Marfan syndrome unless a contraindication exists. E, the risk of aortic dissection during pregnancy in patients with Marfan syndrome is increased if the diameter of the aortic root exceeds 4 cm. Okay, Marfan syndrome is caused by mutation in the fibrillin gene. It is associated with significant morbidity and mortality from cardiovascular causes. The most life-threatening complication is aortic dissection, to which patients with Marfan syndrome are predisposed because of aortic cystic medial degeneration. Such dissections usually commence just above the coronary ostia and may extend into the entire length of the aorta. Beta blockers limit aortic shear stress and can slow the rate of aortic root dilatation. So also angiotensin receptor blockers, due to their effect on the transforming growth factor beta signaling pathway. Randomized trials suggest that either therapy is equally efficacious, and there is some evidence supporting combination therapy with both of them. The dimension of the proximal aorta can be followed serially by transthoracic echo, CT, or MRI. Prophylactic aortic replacement is recommended in patients with Marfan syndrome once the diameter approaches 5 cm to prevent dissection and progressive aortic regurgitation. Some groups recommend replacement even earlier than the diameter, even earlier than 5.0 centimeters. That is, if it's already within the range of 4.5 to 5 cm. So aortic dissection is a potential complication of a pregnancy in patients with Marfan syndrome, and it occurs most commonly between the 3rd trimester and the 1st month postpartum. The risk of dissection in this setting is related to the size of the aortic root and appears to be low in patients with the root diameters of 4 cm or less. Progressive valvular impairments are also common in patients with Marfan syndrome. The risk of severe aortic regurgitation increases as the diameter of the aortic root increases. Mitral valve prolapse, characterized by elongated and redundant leaflets, is detected in 60 to 80% of patients with Marfan syndrome by echocardiography, and progression to severe mitral regurgitation occurs in up to 25% of the patients. So back to the question. Option A, we're looking for the option that is not correct. Option A, some 60 to 80% of patients with Marfan syndrome have mitral valve prolapse on echo. This is a true statement. Option B, the development of aortic regurgitation correlates with the aortic root diameter. This is also correct. Option C, patients with Marfan syndrome should be considered for elective aortic root replacement once the aortic root diameter exceeds 5.5 cm. This is a false statement. It should be done earlier when the aortic root diameter is at 5 cm, or even some groups advocate that it be done between 4.5 to 5 cm. Option D, beta blockers should be administered to all patients with Marfan syndrome unless a contraindication exists. This is a true statement. It helps to prevent the progression of the disease. Option E, the risk of aortic dissection during pregnancy in patients with Marfan syndrome is increased if the diameter of the aortic root exceeds 4 cm. This is also a true statement. So the option that is not correct is option C. That's elective aortic root replacement in patients when the aortic root diameter is more than 5.5. Please, can you move to the last question, which is 659? Hello, Dr. Curry.
I've moved it.
Okay.
It's a bit of a lag.
Okay, I've seen it. Okay, question 659. A 54-year-old man was admitted to the hospital because of acute pulmonary embolism. Intravenous administration of heparin was begun. On admission, the platelet count was 223,000 per microliters. 6 days later, it fell to 36,000 per microliter. Although the patient remained asymptomatic without overt bleeding, which of the following statements regarding the patient's condition is true? A, low molecular weight heparin can be safely substituted for intravenous unfractionated heparin. B, a direct thrombin inhibitor such as bivalirudin should be substituted for heparin. C, intravenous heparin should be continued because the low platelet count represents a laboratory artifact without clinical significance. D, antibodies directed against the platelet glycoprotein 2B3A receptor participate in this disorder. E, this is a transient reaction to heparin and does not preclude further heparin treatment for this patient. Okay. thrombocytopenia that is due to heparin use. So heparin-induced thrombocytopenia is a severe complication that can occur in patients that are exposed to any form or amount of heparin products. It can occur in about 5% of patients who are on heparin therapy. When you have a sudden fall in the platelet counts and the hypercoagulable states, it characterizes the heparin-induced thrombocytopenia, leading to some thromboembolic complications in about 50% of these patients. And it can lead to increased morbidity and mortality, up to 30% mortality in the patients, especially those who have type 2 heparin-induced thrombocytopenia. There are two types of thrombocytopenia that occur in these patients. Type 1 is also known as a heparin-associated thrombocytopenia. It is a non-immune mediated reaction. It's commoner than the type 2 and occurs as early as the first day of heparin therapy. It is usually mild, not associated with a lot of complication, and the platelet count can spontaneously normalize even if the heparin is continued. But the more serious one is the type 2, which is the heparin-induced thrombocytopenia proper. It is an immune and antibody-mediated reaction that occurs after about 5 to 14 days of heparin therapy. This lag is to give time for the antibodies to form if this is the first exposure. But if the patient has had it before and was exposed to heparin again, it can occur even on the first day of heparin therapy. These antibodies, they form against heparin platelet factor 4 complex. And these antibodies bind simultaneously to the heparin platelet factor 4 complex that is found on the platelet receptors. And this action stimulates platelet activation and thrombosis. The diagnosis can be confirmed by the measurement of anti-heparin platelet factor 4 antibodies. You can use an ELISA test, which has a high sensitivity and has a high negative predictive value, such that when it is negative, it rules out the presence of heparin-induced thrombocytopenia. So for the management of patients who have heparin-induced thrombocytopenia, the first thing is to stop the use of heparin. And if there's still a need for anticoagulation, use of a parenteral direct thrombin inhibitors, example bivalirudin or agatroban, can also be used. Also, activated factor 10 molecule like fondaparinux is a synthetic pentasaccharide, can also be used safely in these patients. Lower molecular weight heparin has lower incidence of heparin-induced thrombocytopenia than the unfractionated heparin. However, the antibodies to unfractionated heparin and lower molecular weight heparin, they cross-react, and so it can still lead to this heparin-induced thrombocytopenia. So it's better not to use either of them. So let's quickly go back to the question. Option A, we are looking for the one that is a true statement. Option A, lower molecular weight heparin can be safely substituted for intravenous unfractionated heparin. This is a false statement, like I just explained. Option B, a direct thrombin inhibitor such as bivalirudin should be substituted for heparin. This is a true statement because it's a direct thrombin inhibitor. Doesn't have to go through the same platelet factor 4 complex. Option C, intravenous heparin should be continued because the low platelet count represents a laboratory artifact without clinical significance. This is a false statement. Antibodies directed against the platelet glycoprotein 2B3A receptor participate in this disorder. This is a false statement. It's antibodies against the platelet factor 4 complex. Option E, this is a transient reaction to heparin and does not preclude future heparin treatment for this patient. This is a false statement because for patients who have had this the first time, if you expose the patient to heparin products again, it can start earlier, and even because the antibodies are already pre-existing in the system, to start earlier and even be more serious compared to the first time that the patient had it. Thank you so much. This is the last question for my own part.
Thank you very much. Thank you very much. Any contributions, questions from colleagues? Okay, Charles.
Eugene, I'm here.
Any contributions or any otherwise I
No,
don't
I think
see.
it's time to close the class. Yeah.
Yes. All right. So God will continue tomorrow. Have a wonderful evening.